Moving forward to the first debate of the day, APBI is obsolete in the era of fast forward. I would like to invite Dr. Vikas Jagtap, Head of Radiation Oncology at NIGRIMS, Shillong, to kindly preside over the debate. Thank you.
Very good afternoon to all. And thanks to the organizers for giving me the opportunity for the chairing the session. We'll be going ahead with the debate. The topic is, will the APBI will become absolute in the era of the fast forward trial? We have two esteemed debaters. First is Dr. Sayan Das, who will be speaking for the motion, and Dr. Abhishek Basu will be speaking against the motion. And the time will be 8 plus 2 minutes, 8 minutes, and then followed by 2 minutes of rebuttal. So first I would like to invite Dr. Sayan Das. Dr. Sayan Das is a radiation oncologist and senior consultant and head of the department at Medica Super Specialty Hospital, Kolkata. So Dr. Sayan, please go ahead. Thank you.
Thank you, Dr. Vikas, for this kind introduction. Very good evening to you all. Today's debate is on APBI is obsolete in the, so I move with this, yeah. So APBI is obsolete in the era of fast forward, and I'll be speaking for the motion. Before I begin, I think there is a large number of radongs in the audience. Just a quick question. How many of you have done, say, more than 5 APBIs in the last 2.5 years since the publication of Fast Forward? Kindly raise your hands, please. More than 5 cases of APBI in the last 2.5 years. Well, so is there any debate at all? Okay, let's still go on because no one is doing APBI, at least in the audience. So I just put up some pictures of these items, and what's common with these items is that all of them were once pretty useful and popular, but now obsolete. And I believe that it's time we add APBI to this list. Why? Let's dig deeper. If you ask me that is APBI a valid treatment option in a suitably selected population? Yes, definitely. But should it be used in today's era in 2022? The answer for me is a resounding no. So what are the patients who are suitable for APBI? So there are several guidelines, but overall, so elderly ladies having small tumors less than say 2 to 3 centimeters, node negative, are suitable for APBI. To put things in perspective, if you look at the inclusion criteria of the Fast Forward study, this group was included in this trial. Now there are several approved techniques of APBI. The most commonly used are the interstitial brachytherapy or LINAC based. You can use intraop radiotherapy and mammocyte. Let's spend some time with this slide. I've jotted down this a nice summary of all the landmark trials using partial breast irradiation. Look at the first two, the Hungarian study, the Jekistro, they used brachytherapy, which compared to whole-based radiotherapy, similar local control, better cosmetic outcomes, accepted. The Florence study used IMRT, so a LINAC-based APBI. They also showed similar local control with slightly better cosmetic outcomes. The import low trial was not exactly APBI, but rather PBI. Target and Elliott used intraop radiotherapy, several issues with those trials, and they had slightly increased risk of local recurrence. Let's come to the last two. The RAPID trial, which used 3D CRT, twice daily fractionation, and what it showed was, although local control was similar, but the cosmetic outcomes were worse with APBI, which kind of says that probably 3D CRT is not the way to go. The largest of these studies was the NSABP study, 4,000 patients, which used either LINAC-based or brachytherapy. It's a negative trial because it did not meet the pre-specified equivalence criteria. And most importantly, APBI did not improve cosmetic outcomes. So to summarize, so there is level of evidence of non-inferiority of using PBI with brachytherapy or LINAC-based. However, probably 3D CRT is not the way to go. It may lead to worse outcomes based on the RAPID study. IORT leads to increased risk of local recurrence. Now, there are several issues with APBI. Let's pick one of them one by one, starting with brachytherapy. It's very good talking about brachytherapy in academic meetings, but whenever I ask someone, are you actually doing it? There's an eerie silence. Why? Because it's complex, requires a lot of training, expertise, steep learning curve, and it requires a multi-department collaboration. You need a final histopath report ready within 3 to 4 days. I think TMH is the only center that has been doing it for ages. And even in TMH, in the last 2 years, they've done only 2 brachytherapies. So it's time we call it obsolete. What about EBRT? Preferably IMRT. Target volume dilation is a challenge. Those who have done it know it very well, especially patients undergoing oncoplasty. And if your surgical colleague doesn't put the clips in proper place, it adds to the confusion. Just a representative diagram. IORT is not easily available. You don't have a final HPR when you're doing the procedure. And there's an increased risk of local recurrence. So why take so much problem when I have an easier, simpler solution for you? Which is this one. If you are asked, name one study that has been practice changing in the last decade, I would say this is the one in the field of radiation oncology. We all know it's a randomized trial that compared 14-15 versus 2 1-week schedules, 27 or 26 in 5 fractions. These were the dose constraints. They used tangential pair beams. And if you feel that these dose constraints were difficult to achieve, I'll just share this study, already been discussed, the HYPO trial. They presented their initial safety results. Their dose constraints closely match that of fast forward, and they have shown that they were able to achieve with field-in-field arrangements in almost 100% of the patients. For left-sided, I would suggest you use cardiac sparing techniques which are nowadays available, which can lead to reduced cardiac doses. For setup verification, they used electronic portal imaging with MV or KV X-rays. For 5 fractions, they said it has to be done daily. See, the primary endpoint was ipsilateral breast tumor relapse. The curves are almost hugging. They could claim non-inferiority for both the test arms. However, for cosmetic outcomes, what was seen that the 27 gray arm was worse, but the 26 gray arm kind of was similar to the 40 gray arm, both for clinician assessed as well as for patient reported outcomes. So to summarize this study, both schedules were non-inferior, normal tissue effects. 26 gray was similar to the 3-week schedule, and 1 week is obviously more convenient for the patient, substantially less expensive, and for the patient as well as for the health service globally. However, what I feel is there a lot of reluctance among the radiation oncologists for clinical introduction of extreme hyperfractionation. It's not only for breast, but for prostate and rectum as well. But we must accept that extreme hyperfractionation is a concrete reality. Probably people are skeptical of the results. They want long-term results and probably delay in information flow, which is why we need more such debates. Infrastructure and financial challenges, as I showed, there is no added cost. To address the concerns for late toxicity, what these several landmark trials of using moderate hyperfractionation and extreme hyperfractionation shows that the changes appear early, which kind of stabilize over the years. The Wayland trial, you see 5 years and 10-year results were almost similar. START-P trial as well, the hazard ratio between for breast income between the 2 arms is 0.83 at 5 years and 0.8 at 10 years. So it kind of remains the same. The absolute values may increase, but the relationship between the arms remain the same. Same for fast trial as well. The RAPID trial, the significant difference in cost mass is shown by 3 years. It's kind of stabilized by 5 years. It kind of moves on as time progresses. BOOST trial, 20 years follow-up. You look at the results, 10 years, 28% versus 13%. Remains the same at 20 years, 30 versus 15%. START-B showed that ischemic heart disease and symptomatic lung fibrosis and even rib fracture were rare and not really different between 5 and 10 years. So don't wait for 10 years. Start practicing fast forward. Before I finish, the UK consensus statement already has mentioned look at statement 4 that offer 2016-5 for partial breast radiotherapy. Before I finish, this picture, I think, perfectly sums up the current scenario. Thank you.
Thank you, Dr. Sai. You just finished in time. So I request you to please be seated on the front only. And next I request against the motion, Dr. Abhishek Basu, who is the Associate Professor in the Department of Radiation Oncology at Bardhaman Medical College and Hospital. Thank you.
So at the outset, I would like to thank Dr. Prashanjit Chatterjee and Dr. Shayan Pal for giving me this opportunity. And it's always fun to debate on a Saturday afternoon, and even more so when the debate topic is very loaded. So it's not any fun to debate something which has no spice in it. So what I'll try to do in the next 8 minutes is to give you the overview of why I think APBI is not obsolete in the era of fast forward. And just to start, I think, although I could have put both our pictures here, I think it is important that I looked at two of these great surgeons who have completely changed the paradigm of how we look at breast cancer, and I'll come to it why I have put it. So, APBI is obsolete in the era of fast forward. So this is the thing that we are trying to debate, and obsolete, as we all know, for the sake of just pondering on it, no longer produced or used. So it is nowhere used across the world. So that is the thing that we are trying to debate. So what are we actually debating? Even my 4-year-old daughter actually knows the difference between these two shapes. One is a whole and one is a part. And coming to the question of volume, I think every student of radiation oncology is well versed with this concept that even a 5 millimeter thick pill of the orange leads to almost the equivalent volume. So essentially, in radiotherapy, we are trying to reduce volumes across the board when we are trying to treat. Of course, in this case, maybe not, as my learned opponent just told us. The only similarity, mark my words, the only similarity between these two regimes is the treatment time. And that is about 5 days, which is the external, the fast forward, as well as most of the cases of APBI. But as we'll show in the fewer slides, there is a hole in the hole. Again, it is important to note what we are not debating. We are not debating whether APBI is better or worse compared to fast forward. We are only debating APBI is obsolete in the era of fast forward. And of course, we can take picks as to who is best with a preconceived notion, but that is not what we should be doing. We should actually be debating in a spirit of harmony, as we can see two arch rivals here, and perhaps not like this. And I hope certainly we would not do this. Coming to the historical evolution of breast radiotherapy, and this is again a seminal paper which all surgeons know, important to note that breast conservation surgery actually led to increased local recurrences but did not impact overall survival. And this has completely changed the paradigm of treatment of breast cancer in terms of surgery. And we also knew from here that these recurrences occur in the index quadrant, in the vicinity of the primary tumor, which has led to the entire change in the concept of delivering radiotherapy, where the dose per fraction has perpetually increased, the treatment time has gone down, and the treated volume has also gone down. Whether you do the question of whole breast, we are trying to decrease the volume. Even when we are doing a boost, we are trying to decrease the volume. And this is how it has evolved. So I'll skip over this slide quickly because my opponent has already shown you this. The evolution of breast radiotherapy coming to the UK FAST trial and thereby to the fast forward trial. But before we move to the question of APBI, it is important to ponder on some aspects of the fast forward trial. There were protocol amendments made in the trial to actually exclude the very low risk patients. There were questions raised by the trial authors already whether it was generalizable, and that point was alluded to by Dr. Chatterjee in his talk previously. Post-mastectomy RT in the selected group of patients was used only in 6 to 7%. Boost, most importantly, was not given to all. It was left to investigator discretion, and only 2/3 of the high-risk patients received a boost. Nodal irradiation again was not allowed in the main study. I know there's a sub-study, but we don't have the results out yet. And no formal subgroup analysis was done. And as we looked at this, it is very important that only one gray increment actually led to a detriment in the local, in terms of the late toxicities. And this is important if you look at the BED values. We already have the HIPORT, the early toxicity data is there. I think this is possibly, if I may say, a better design trial, because that will also be looking at boost within the primary radiotherapy and also node early radiation. Coming to the different types of APBI, which has already been shown, so I'll skip over these trials. Definitely there is no question that APBI is not for all patients. Again, the fast forward is again also for not all the patients. So this is something that we need to be very cognizant about. It is for a selected group of patients, and we have to appropriately select out those patients who are candidates for either of these treatment regimes that we do. And this is important, especially for people who are starting on the learning curve, either for the fast forward extreme hypofractionation or for APBI. These trials again have been shown by my learned opponent. So what I'll try to just quickly run through is what were the problems of the earlier APBI trials and what were corrected later. So brachytherapy trials were definitely better because the volume of irradiation was small. And coming to whether you use brachytherapy or not, I think this is more or less the same case even for using interstitial brachytherapy for carcinoma cervix, where it is a mandate. So it's entirely a matter of practice. I would slightly differ from my opponent in saying that you do not use brachytherapy. I have myself used breast brachytherapy in a number of patients, including APBI. Coming to rapid, definitely there were more toxicities, but that was because the dose was more, and we know that even 1 grade dose led to inferior cosmesis in the fast forward trial. The NSE-BP-B39, a trial whose design has been widely criticized by many, including a very beautiful paper by Chirag Shah in brachytherapy, and we know that the final outcome results have only been reported in abstract form. Okay? It was a heterogeneous trial, and the outcome that they were looking at was not properly designed. So that was the major issue with this trial. Coming to the second generation trials, which were using IMRT photon, you can see clearly that these trials were positive. In terms of they had good local control, which was comparable, and definitely lesser toxicities, and I think my opponent also talked about this. Several publications are also there from India, although these are not very large patient numbers, but they are definitely there. And resoundingly, I would say that APBI is here to stay. There are meta-analysis of APBI which actually look at the more than 10,000 patients in different scenarios, and they have said clearly that local control is equivalent and toxicities are lesser. And there are unique clinical scenarios actually, although these are small reports, but where APBI can be used. In patients not suitable for external beam radiotherapy, where you want to further reduce the cardiac dose, especially with brachytherapy, in elderly women who would not otherwise be candidates, or where you want to use very accelerated APBI, 3 fractions 7.5 grade. These are all reported in good journals, although may not be outside of clinical practice. So in summary of APBI, there is clear rationale to treat. Certainly it is not for all, but in suitable patients it's a good tool, and the evidence I think is robust, and if I may so, is more than the fast forward trial, because both in terms of time and patient numbers, fast forward still needs to be implemented for generalizability. And interestingly, a number of premier organizations all across the world clearly endorse APBI as of 2022. Coming to the RCR guidelines, which my opponent also showed, you can see very, very clearly that they clearly said that partial breast irradiation in terms of the import low, I agree, I completely agree that this is a part of APBI, but it is definitely the partial breast, not the full breast, is important, and 84% of the patients said that it is completely relevant in 2021. Now the question of whether we practice it, obviously, how do we want to evolve? We want to evolve like this or this, it's completely up to us. So I would say that we would want to definitely practice it. It's no quiz that you want to eke out an answer by force. If you want to practice, APBI is completely relevant. And because of that, I did one last thing. I thought, because Dr. Murray Brandt was not coming to this meeting, I thought of mailing him. And this is the answer that Dr. Brandt actually gave me. So I think this summarizes the debate. There's no more debate here because the PI is clearly saying that APBI is still relevant for appropriate breast cancers. So it is acceptable, pragmatic, and maybe I'll end here by quoting Dr. Robert Hutchison, a very well-known quote, "From inability to let well alone, from too much zeal for new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, good Lord deliver." Thank you.
Thank you. I request Abhishek to please be seated. Now is the time for rebuttal, and I request Dr. Sayan Das to please come forward. And please stick to the time. Abhishek, you are a little bit over the time.
Yeah. Hi. So thank you once again. Just a few points. My learned colleague was kind of trying to find faults in the fast-forward study. He was alluding to very few chest wall patients. The sub-study of nodal irradiation is not yet available. But that's not relevant for this discussion at all. We're talking about APBI, not post-mastectomy patients, not node-positive patients. This did exclude the low-risk group of patients who probably do not need radiotherapy, leave alone APBI or fast-forward. So again, that's not relevant. NSABP, the largest study, yes, there were issues regarding the methodology, but bottom line, APBI did not improve cosmetic or outcomes or late toxicity. Brachytherapy, yes, it all depends on practice, but my question is, who are practicing it? Nobody, excepting few premier centers. So it requires a lot of training, skill, and unfortunately we lack that. We better accept it. And when you have a much simpler solution, why go after such complex techniques? My learned colleague did show some small studies where EBRT is not feasible and all those, but comparing such small single-centered studies vis-a-vis a well-conducted phase 3 randomized trial, I'll leave it to the audience. Thank you.
Thank you. Thank you, Dr. Sain. I request Dr. Abhishek to come forward for the rebuttal.
So again, just to make it very simple, I think we are confusing the topic, right? So the topic was whether APBI is obsolete. The question is not of comparing APBI with fast forward. There are clear niches for both. It should be a question of the person who's treating the breast cancer to select whether partial breast irradiation would be required or whole breast radiation would be required. So the moot question of what we are discussing is this. Coming to the modality of giving APBI, again, that is completely left to the person. My learned colleague already showed you clearly that using electron and intraoperative, which are also forms of APBI, have clearly been shown to be inferior and have gone out. So we have to select the best form of APBI versus the best form of whole breast radiation and then do a comparison. Unfortunately, as has clearly been mentioned both by RCR and by Dr. Mare Brandt, such a study will not be at least designed by the Royal College because they already have the import law as well as the fast forward, which were designed in parallel, and they are very confident in their statement, stating that both partial breast as well as whole breast are relevant options. So the only moot question that I would like to say is that something which is being less used is not obsolete. Do not say that APBI is obsolete. It is a valid option. It's completely up to the audience to choose whether they would be using fast forward versus APBI. And just to give you an example, there were 7 radiation oncologists on the panel for the early breast panel just now. The question was asked regarding APBI. I think 2 persons raised their hand among 7, and only one of those 2 said that they would be using it outside clinical trial. So the majority of radiation oncologist faculty in this conference, they were not using the fast forward regime. In spite of using, so all of them said it's moderate hypofractionation. Does that make fast forward bad? No. It's just a question of practice. So I rest my case. Thank you so much.
Thank you. Thank you to both the speakers. So just we need to improve the brachytherapy skills in the current era of technology. I will not announce the result. I'll just ask the audience who feels that APBI will be absolute in the era of fast forward. Just raise their hands. And who feels the APBI is here to stay and it will continue till the long time. So the result is already there. Thank you so much. Thanks to both the speakers.
Thank you, Dr. Vikas Jagtap, Dr. Sayan Das, and Dr. Abhishek Basu for the excellent debate.